very much. Can you hear me clearly?
Yes.
Great. Wonderful being with you. And it was a very thought-provoking address which my friend Dr. Anurag Batra delivered. He spoke of success defined through a fluke and a book called Fluke. Failure or mishaps can also be defined by flukes. So a failure is a freak fluke or a mishap is a freak fluke. And I really admire those people who succeed, and I admire more those people who go through failures and come out winners or at least survive those failures through their resilience. So I'm very happy to be here among such resilient people. And thank you very much, Business World, for inviting me. I also agree with the other point which Dr. Anurag made, that hospitals are more bothered about their health rather than patients' health. In fact, a couple of hospital owners yesterday were at my place in the evening, including Dr. Harsh Mahajan. Of course, he owns imaging this thing and others. And I told our hospital owner कि आपके हॉस्पिटल में दिल के दौरे से तो पेशेंट बच जाता है, लेकिन बिल के दौरे से मर जाता है. ओके, सो ये भी एक बहुत इंपॉर्टेंट पॉइंट है जिसपे भी कभी बात करनी चाहिए बिजनेस वर्ल्ड को. द थर्ड पॉइंट विच डॉक्टर बत्रा मेड वाज स्लीप. इट्स रियली a rejuvenator, a resilience maker. I have a small coaching practice and I have the pleasure of learning from several people who have gone through tough diseases that morning में नींद खुल जाती है टेंशन के कारण. ये टेंशन होती है कि बच्चों का क्या होगा, इस तरह की और अलग अलग टेंशन्स होती हैं. मेरे को ही क्यों हुआ, कई बार यही टेंशन से नींद खुल जाती है. तो इन चीजों के बारे में भी incremental additions I'll seek from the audience. And on that note, I thank Business World and I thank you all and I admire all those people who have gone through this this very terrible journey of cancer and emerged safe. Let me start with Dr. Dhar. Dr. Dhar, how do you think that the incidence of cancer and the socio-economic effect of cancer has changed over time? More the incidence of cancer, I'd like to ask you, and for socio-economics, I'll come to my other friend, Sanjeev.
Yeah, when we talk of incidence, it reminds me the magnitude of problem. The magnitude of problem of cancer has drastically increased. In 90s or late 80s, when I started my career as medical oncologist, we hardly saw cancer patient or heard of cancer patients in our neighborhood. But these days, every alternate family is having a cancer patient. That is a rough way of telling that the magnitude of cancer or the incidence of cancer has increased. But coming to the hard facts, and what are these hard facts? Earlier, there were no statistical methods to measure the magnitude of problem all over the world. But these days, all these things are being monitored by Globicon data. And it is estimated that every year, about 2 to 2.5 million new cases are occurring. And I'm sorry to say that about 1/3 of these patients die every year. As far as India is concerned, India is a developing country, and cancer was supposed to be the disease of Western countries, disease of rich. But our country, unfortunately, has taken a lead in this. The incidence of cancer is rising very, very rapidly, and somebody says that there is epidemic of cancer in our country. So, what are the cancers which are increasing? I will specifically name 3 or 4 cancers, and these are breast cancer in ladies, cervix cancer in ladies, and in males, they are head and neck cancer and lung cancer. A single point or single line regarding the cause why it is increasing so rapidly. Cervix cancer, it's a poor woman's disease. It is because of bad hygiene, dirtiness, and bad sexual hygiene, having multiple sexual partners. Breast cancer in urban population, it is increasing very fast, and it is mainly because of lifestyle changes. That means smoking, alcohol, lack of exercise, fatty diets, putting on weight, and stress. Oral cancers and head and neck cancers, they are basically because of tobacco chewing, very common, and particularly in rural population. And lung cancer is because of 2 things. I feel 2 factors they contribute to the lung cancer causation, and these are smoking, and there is one gas which is called radon gas, which is usually emitted in crowded areas which are humid, where the water does not dry as quickly as it is required. And this gas is responsible. So overall, we can say, whatever I have told you, all these factors can be corrected, and these factors are corrected, we can decrease the incidence of cancer.
Wonderful. So, in summary, cancer is becoming an epidemic, and cancer of cervix, breast cancer, and lung cancer are really burgeoning. Let me come to Sanjeev. Sanjeev, what would you like to incrementally add to what Dr. Dhar has said, and also the socio-economic side?
Yeah, thanks, Pavanji, and I think very eloquently put up by Dr. Dhar. कहते हैं ना डर के आगे जीत है. So first of all, kudos to all the survivors. You are warriors. As very nicely put up by the. So the moment a common man thinks about cancer, it sends a chill down your spine. It's some word. If I take you back, like Dr. Dhar was mentioning, in 1990s or late 80s, it was an alien disease which could never happen to us. Or we used to hear cancer happened to somebody known to that somebody. But now in every household, at least in the wider family, you'll have a few cases of cancer. Unfortunately, I lost my brother-in-law, my younger sister's husband, to cancer a few years back. He himself was a cardiologist, a good man. He had this CLL, and CLL people generally survive for 18, 19 years. But then he was gone because there was this element of Richter's transformation of CLL, which is again some intricacy I don't know. I mean, far more erudite people would be able to talk about it. Now, talking about the incidence of cancer, while statistics are known to many of us, there are about 16 lakh cases today, and that translates to, out of a population of 1 lakh people, 101 people they're having cancer. Now, last year alone, out of about 15 lakh 62 people, 8.75 lakh people died out of cancer, which makes the mortality to be about 55-56%. Now, why is it? Was this preventable? I think we'll dwell on it during the course of our discussion. Another thing which is very, very important to know is that there's a huge risk in our lifetime. So 1 out of 9 people in their lifetime are bound to get cancer, as per the statistics which are available to us, which means 11% of the people in the country are susceptible to getting cancer. Now, talking about, as Pavanji asked me, the socio-economic impact or the financial impact of this, Dr. Dhar mentioned about oral cancer. There was a study which was conducted in the central rural India, which mentioned that even in the government hospitals, the spent on for the treatment of oral cancer is about ₹1 lakh. Imagine a country where the per capita income is just about ₹2 lakh per annum, from where a poor guy is going to get this kind of money. And given the fact that 75% of the healthcare is dispensed in our country by private sector, any cancer, the average spend is about 3.3 lakhs per annum. So imagine a family, the household income is just about 2 lakhs, 3.3 lakhs per annum spent on cancer. So in my earlier days, when I used to run a few hospitals for Fortis, I used to see people, they coming to the hospitals after selling their properties, exhausting all their savings. It's heart-wrenching, to say the least. But yes, this is what we have to deal with. The only way is prevention. Another thing which I thought is worth sharing with you is that it is not just about this kind of direct impact. There's a loss of productivity. A person who's sick can't work. There's a loss of productivity to the nation. At the national level also is a big loss. Then the caregiver time. The people who are in the family, it is something which has to be dealt with by the family. It is not something which is endured by an individual. So the gravity it becomes multifold. And obviously, there's so much of psychological stress which one has to endure through. So given the low paying proclivity in our country of the people, the masses who don't have much of paying propensity, the common thing which happens across the board, which we have seen, is this delay in treatment because they want to defer the thing, and that can be devastating. Second is a lot of dropouts. Because of want of funding, want of money, people are not able to sustain the expensive treatment. So this is something which plays havoc, and I hope that we are able to come together as a country, as society, and able to do something to deal with this menace which is turning into a monster.
For many of you, what Sanjeev has said about 1 lakh rupees being a big sum, I'm just reminded another friend of mine who owns a hospital in a tier 2 town. He sends his ambulance every few days to check if somebody is ailing somewhere and needs help. This ambulance people found a man about 60 years of age lying in his porch, and he was in a little awkward position. They felt that because he's attended by his members and our family members are all around, so they left. After 2-3 days, they saw the mattress has come there, and there's a pot also for water, etc. And that guy is still lying in an awkward position. So they went and asked him that, how come you're lying outside your home, etc. Then they saw that his femur was broken. Femur is the long bone here. It was completely broken at 90 degrees or 80 degrees. And it had been broken for that much time. And he broke it there only. So they had made their the mattress and all to wait for Sunday to come, when they will have enough money or they will have a holiday for the man to be taken. So when cancer comes in a poor country, poor family, it is havoc. People start thinking, oh my God, how will I handle my father's cancer? Many a time, doctors tell that the son is telling, father, आपने कुछ किया नहीं, लेकिन आप कैंसर ले आए. इस तरह का ह्यूमिलिएशन उसको फेस करना पड़ता है. फिर वो बाबाओं के पास जाता है वगैरह. तो deep socio-economic impact. And on that note, I'll come to Dr. Geetanjali Nanda. How do you feel that the incidence of cancer has changed in your practice, and patient caregivers, how are they responding?
Good morning, everyone, and a big shout out to all the cancer warriors here. I can see that the majority of them are females. So breast cancer is the most common cancer amongst women in India. And we live in a country where the word breast is not spoken. 80% of the females have not spoken this word in their entire lives. And the moment they have this lump in a breast, how do they tell anybody? It's like a stigma, and they don't want to tell anybody that they've got a lump. So it takes almost months and months to decide in their minds that finally they're going to tell somebody, come to the doctor and get it examined, which is again a big social stigma. So we are living in a country where a lot of norms and stigmas are there. But the only way to survive a cancer is to pick it up early. And a stage 1 cancer is completely curable and costs less on the pocket as well. The moment we go to stage 3 and 4 cancers, it amounts to radiation, chemotherapy, injections for next 10 years, and it is a lot of money involved. So the first thing is that we need to sensitize people around us that cancer is curable. If somebody has a diabetes, I mean, we're not making him as a victim that he created that diabetes. But the moment somebody has cancer, it is as if he's got a death sentence on his head. And we're looking at their faces that you have got cancer. I'll tell you my own story. My father, he had cancer for 10 years. He never told anybody. He didn't want anybody to look him at with pity कि इनको कैंसर हो गया है. मैं कहा पापा डायबिटीज तो बता देते हो. वो कहता डायबिटीज का क्या होता है, सबको होता है. मैं कहा कैंसर भी सभी को हो रहा है. There's nobody there's no family जिसमें कैंसर नहीं हो रहा है. So I have been the caregiver for 10 years, and it is not an easy task. So in our country, what is the difference from the Western world is, especially for breast cancer, that the females are younger. The incidence in Western countries, especially UK, the females are getting breast cancer is 60 to 65 years of age. In last 15 years, I've seen the patients are getting younger. Now nobody comes in their 65s. Everybody is coming in their 40s. So हमारे बीच में एक joke होता है कि 40 और 50 के बीच में बच गए तो बच गए बाबा. It's like everybody who's young. Now 40s and 50s is the age where you have to raise your family. Your child is a teenager. The moment they come to know that the mother has got a cancer, it has psychological impact on the child. The woman can't work, so it's a big hit on their income, and everything amounts together to a lot of psychological, medical, and socioeconomic impact on the whole family. So what I feel is that there needs to be, I'm very happy to come on this platform and talk about it, because there is a need for open dialogue. I mean, the top 3 cancers for females: ovarian, cervix, and breast. We can, prevent them a little bit by talking about it. Cervical cancer, there are vaccines, but nobody knows about it. The HPV vaccine is given to boys and girls both. Nobody knows about it. And for men, a prostate cancer is very common, but nobody gets a PSA test done. So we have to sensitize our families that, we have to pick all these cancers earlier, and we have to get rid of them. It is not that, we have to come late and then we have to deal with all these situations. Pick it up, get rid of it, and, get done with it and move on. I mean, it's like, tell everybody that we have to come, whatever can be, diagnosed can be cured. Whatever can be tested can be cured. But we can't sit on it. That is the whole point.
Correct. Very good point. In fact, underscoring I love the point that the patient of cancer is not only a patient, he is also the accused. तुम लाए, diabetes तो आ गई, लेकिन cancer आप लाए, because many of the triggers of cancer are like smoking, etc., which are related to lifestyle. So, great points. Yeah, please go ahead, Sanjeev.
Just to add, cost of diagnosis is only a fraction of a cost of treatment. We don't realize this. We are all said and done. We understand the low paying propensity of the people, yet we are blessed to be in India. I can tell you, I've got a large number of family members who are settled abroad, including my kids. A simple test, since we're talking about breast cancer, BRCA, it costs at least $1,200 over there, which we do it for $100, using the same equipment, better manpower, better doctors, right? So what I'm saying is that, in fact, breast cancer and cervix cancer especially, they are preventable. In fact, I took this, last year I went to the EBC and I started my campaign to, kind of prevent the cervical cancer from the roof of the world. I carried a lot of, banners over there and we did that. So I thought, in our limited way, if we are able to do something, that will be a great help.
what is it that you'd like to incrementally add to what has been discussed so far regarding the incidence, socio-economic impact, or what is the difference you are seeing today in your practice?
So actually, that's a very valid point. And before this session, I was discussing this point with one of the panelists who's going to be on the next session. And we were thinking, as doctors, we tend to think from a doctor's point of view. How many of us really think from what the patient or his or her family is going through? For example, being a radiologist and then doing interventional radiology, we kind of get looped into the patient care when probably all options run out. In terms of all surgical options has happened, all medical oncology options have been taken care of, radiation oncology options have been taken care of. But at the very end, we feel that we get a reference कि अच्छा ठीक है डॉक्टर अभिषेक पर देख लो आप कुछ कर सकते हैं क्या पेशेंट के लिए और हम कुछ कर सकते हैं क्या बट क्या ये अप्रोच हम शुरू से भी शुरू कर सकते हैं isn't it can't we all the doctors sit holistically in terms of this is what the patient is, this is what the cancer is, everybody's talked about the big impact both financially, socially, mentally, everything. So I think the time big cancer hospitals these days or big cancer practices these days are doing what we call as MDTs, which is multidisciplinary discussions, wherein all the doctors sit together and discuss what's going to be best for this patient in a least invasive manner. Because as we have discussed, evidently it's turning into an epidemic. And the earlier we start thinking from a patient's perspective, be it economically, be it socially, be it mentally, I think we will be able to offer that personalized treatment much more. So adding to the point that you said initially that कि दिल के दौरे से तो बच जाओगे but पैसे के दौरे से कैसे बचोगे? बिल के दौरे से. So I think if we can just take a raise of hands, I think how many of us ever fallen ill? I think some few people haven't. How many of ever visited a government hospital for your treatment? I did MBBS from a government college. So I kind of got injections there. So this speaks volumes that it is not just a discussion sitting amongst doctors or hospital owners or management chains. I think the government's role is a big role to play into it. I remember during my parents' time, there weren't any private hospitals. And my dad retired from a government job. And I think who of the government of India used to know him because that time there were no private hospitals and everybody had to go to a government hospital and the treatment and the facilities were such good. So I think somewhere down the line, we talked about the figure of 75% of healthcare being provided by private health industry. So I think it is time that the government steps up, not just overall, but even for oncology. I think it's a huge discussion again. I just wanted to touch base on that.
Oh, wonderful. So, very good points. Because we have only 12 minutes left, and I would like to also take a couple of points from the audience, I request the panelists to speak in telegraphic code and only on 2 points. One is research in diagnostics and research, or let me say innovation in diagnostics and innovation in therapy. Let me start with innovation in diagnostics with Sanjeev.
So I've been, you've instructed me to be telegraphic, so I'll talk about only 3-4 things.
Yeah.
One is when we talk about innovation, let's just divide into 3 parts as far as diagnostics goes. And I've got a friend here, she's going to talk about radiology. I'll try to be, kind of stick to pathology. So one is the AI or the machine learning aspect. Everybody, so much of hyperbole has been created around artificial intelligence, machine learning and all. This was there 30 years back also. Whatever, dashboards used to make, I was telling Pavanji some time back that, small things we used to do at the back end, you required some algorithms right from the time we used to have Lotus 1, 2, 3 when I started my career 35 years back. So that was all nothing but, just machine learning only. But the point is that now this is assumed bigger proportions. And what we see is that through AI, we are able to recognize the patterns, right? Be it imaging on the MRI side, mammography side, even slides. If you're able to create those back-end algorithms which are able to decipher, okay, this kind of structure would mean something, then the work of a pathologist or a radiologist would actually be aided tremendously. Let's not forget, in our country, there are about 300,000, 3 lakh labs, and only about 29,000 qualified MD pathologists, biochemists, and microbiologists. There's so much of dearth of such species. The doctors who I'm surrounded with, they are a rare species. Let me just tell you this. So if we are able to do something worthwhile using AI, I think that will be a big deal. Similarly, as we are building large and large database, this analytical capability is going to get enhanced. And then the results would be far, far better than what those are perceived to be now. Second is the digital pathology. So the first is the AI/ML, second is the digital pathology. Now, what do you mean by digital pathology? As I said, these resources are very scarce, these human resources, the doctors. How can we ensure that if somebody sitting in, let's say, Tiruchirappalli or say Timbuktu or, those Bhavnagars of the world, to get diagnostics in a timely manner? Can we create a pool of pathologists sitting in, let's say, in Delhi or Bombay, and remotely send the slides from there through, instead of sending the slides, the digital images? So that's digital pathology for you. It is very good, if you talk about digital pathology, it's very good for such remote locations, dealing with such remote patients who are staying in remote places or far off places, even for getting the second opinions. This can really work wonders. Third, I would like to dwell on the new technologies. Now, how these new technologies are really aiding us. One is, some of these technologies, the tests that we are bringing, are a little bit predictive in nature. Where there's a predisposition of a disease, we are able to check or screen those patients and are able to detect the problems in an early stage. So that is something we've been talking about: prevention. We're talking about early detection, and stage 1, as Dr. Nanda just mentioned, early detection can work wonders for the patients. Second is, it is easy detection also. When I say easy detection, it is affordable. You don't have to spend so much of money. Not only we are diagnosing or screening the patients in time, we are aiding treatment also, because the care is becoming more and more personalized. There are tests which can be, which can be used as towards what we call as a personalized medicine. And of course, monitoring the disease, how the disease is progressing. If you are able to get those tests done on a periodical basis, you know whether the disease is contained or it's actually configurating or it's coming down. So I'll only talk about now two technologies which we feel which would be relevant here. One we talk about is the genetic testing, what we call as next gen sequencing. So gone are the days when we used to only talk about the PCRs and the RT-PCRs. Now we've got Sanger sequencers on the pathology side, and next gen sequencing also. Now if you have to do the germline mutation testing, for instance, I spoke about BRCA test. The BRCA test is to detect the mutation in breast cancer, ovarian cancer, prostate cancer, pancreatic cancer. So through this NGS testing, we are able to if there's a predisposition, there's a familial history, we are able to detect, oh, this person is susceptible to getting this. Let's get him or her tested. Second is the APC, what we call as the adenomatous polyposis coli. This is a gene which works like a brake. So what happens is that when the cells, it is basically is kind of a gene which prohibits the cells to grow multifold and form a tumor. And if this gene is mutated, APC gene is mutated, then what happens is that the cells go berserk and they actually start forming polyps in our intestine or colon, which gives way to colon cancer, rectal cancer, which again is a big problem. Right? Similarly, we've got even leukemias, whether it's AML or ALL. We find that these genetic testing can be really used as a kind of a preventive measure. Not really preventive, but yeah, if there's a predisposition, you are able to handle that in a far better way. Similarly, now's the time when we talk more about liquid biopsies. So there's, earlier we used to have this circular tumor cell, CTC technology. Now we're talking about ctDNA, where in our body, even the small traces or small fragments of DNA can be tested, and we can find out that the person has got. And this is just a blood, by the way. You just have to take a blood sample. You don't have to do anything. We take the plasma, and through that we can tell that the person has got some kind of a cancer which is there in the body of the, So I'll stop at this. I know.
No, wonderful. I understand your passion, and it was a very informed piece. On the liquid biopsies is clear. The genomics part means that the genetics of the tumor is studied. So then the medicine and the prognosis, etc., is given accordingly. Great points, Sanjeev. Would you like to quickly add something to this, Dr. Geetanjali? Then I go to the changes in therapy.
So I'll just add on to the 4 points that Mr. Sanjeev has said. First is prevention. So when you're talking about preventive health checkups, we are not talking about those 550 blood tests in 800 rupees. We're talking about personalized age bracket health checkups, depending upon your family history, your genetic lineage, and your age bracket. We should tailor the preventive health checkups. So for that, we have a lot of diagnostic options that are available. I'll just touch upon a whole body MRI. Recently, I had a patient, 2 patients actually, 2 siblings, who lost their mother to cancer, and they both turned up and said, "Hamara whole body MRI kar do, hamare paas cancer to nahi hai." So it's not like, it's not a jadoo that is happening. Whole body MRIs are available to find out abnormalities. But then again, after that, we should do a more tailored imaging test for those particular diseases. Second, whatever innovation that we have in diagnosis, there are endless innovations. In diagnostics, we have not moved away from not just finding the tumor, but up to finding how it behaves, what is the biology of it, and how will it behave in future. So we have moved from radiology to radiomics and radiogenomics, which attaches the radiological diagnosis with the genome testing as well. In therapeutics, what we do is that we have targeted approach, like we have automated, like we talked about AI. So we have AI-based segmentation of tumor. We have a lot of augmented reality software. So what we do is, if somebody has a tumor, we can do a 3D CT or an MRI for that patient. The surgeon can, in real time, do a VR goggle surgery virtually before going inside and doing the real surgery. That way, they can avoid all the unforeseen complications. They are very ready for that surgery. And it saves the patient from blood loss and unnecessary complications. Also, during onco treatment, we can, monitor the treatment part in chemotherapy and find out whether the chemo is working or not. So it saves the patient from unnecessary chemotherapy and unnecessary side effects. And for prognostication also, we have a lot of genomic and radiology testing together, in which we can predict whether this treatment, this tumor is aggressive, it is going to come back, whether this patient needs extra medication for that. So in all the 4 aspects, there are a lot of testings available in radiology and a lot of innovation coming up. We started working with this AI in 2017. From then, we have seen leaps and bounds, number of algorithms, number of testings, a lot of data has come up. So it is very promising how it can, shorten the treatment and make it so much personalized that the patient does not have to suffer from the side effects of it.
Wonderful, wonderful addition, Geetanjali, to the base beautifully set by Sanjeev. Dr. Dhar, what are the changes, innovations coming in treatment?
Yeah, how much time I am allowed?
You have 2 minutes, because then we'll open the floor.
I'll finish in 1.5, sir.
Okay, wonderful, sir. Wonderful, sir.
See, if you talk of the innovation in the treatment of cancer patients, I will say only one word. That is precision oncology. Now, it's my job to make you understand in another 1 minute and 30 seconds. 1 minute and 30 seconds that what is precision oncology. Precision oncology is that you show me the patient, I will give you the treatment. Because same boot does not fit all. Earlier, we used to give for same disease the same treatment to all the patients. Now we individualize it. That this is gentleman, he has got these characters, he has got this genomics, he has got this histopathology. So we have to streamline the treatment. The rest is stem cell transplantation, bone marrow transplantation, which has come into existence for last 3-4 decades, which has improved the survival. CAR T cell therapy is the latest treatment for cancer. And immunotherapy and targeted therapy. These are the 2 molecules which has revolutionized the treatment in cancer. Because they are effective, the side effects are minimum, they have improved the survival, and they are even effective in elderly patient. My last word, last sentence to the audience is, please do not neglect your elderly. Patients say, ये तो अभी 80 साल हो गया, अभी क्या करना है? No. I got 4 elderly patients in my own family. I treated them successfully, and everybody is around 90 years of age. And I have made a documentary of these patients. Thank you very much.
Wonderfully compact and condensed everything in one word, Dr. Saab. Precision oncology. Wonderful. I open the floor to the audience for any sharp questions, comments in. Request you telegraphic code. Please. Yes, please, sir. Audience mic दीजिए. Mic there.
I'm here with a background of healthcare management hospitals. But for about 8 months, I was a youngster in the family, 38, background in RCC. I've been treated overseas. My opinion is obviously because I have reached internally the system here in India. I said, great, that copy of the process protocol they have, that coverage and which we have. The bigger difference I would like to ask to this is why the same patient, the same disease, 3 doctors with 3 different diseases. A simple thing, the youngster had a stroke, he had a finding of earlobe, Dhar, who was closed, waited 6-7 months for the surgery to happen, for the stroke happened. The simple thing that he was an aspirin, and aspirin has to be stopped as per their protocol 7 days before the surgery. And I spoke to 5 very senior surgeons here, and they gave me wait from saying we will stop it by 1 day before, we will not stop it, to saying we will take it on temporary. And I am not a doctor, but I'm still a compounder. I spent 25 years of healthcare managing. I am at loss as to which one to take it also. I have 4 opinions, stop for 7 days, the stroke patient, 8 months into this, risk is there, taking over heparin, stop it 12 hours before, not stopping it. We talk about advancement. The basic system of health, basic protocol, the standard protocol is still something which we could respect. Sorry for the long
Dr. Dhar.
Can you summarize in one sentence, please, sir?
why do we have different protocols for the same set of disease for the same patient as simple as stopping a blood thinner or a partial effect?
Absolutely, you're right, sir. There is a definite protocol of stopping blood thinners before surgery. Now, whether this is aspirin, whether this is heparin, or whether this is oral anticoagulants. These are the 3 sets, sir. Now, aspirin is usually stopped 3 days prior to surgery. Usually. There may be other alternatives. And if you come to the oral coagulants, it depends upon the half-life of oral anticoagulants. We have to stop between, say, 5 to 7 days. But heparin, we usually stop between 12 to 24 hours before surgery. Again, restart it after 24 hours of surgery. This is the general guidelines, but it may vary from patient to patient.
Question, I think, is very clear, very targeted. Why have the same protocol only by the doctor's choice? They still practicing and trying to find different solutions for the same patient, for the same symptoms.
Yeah, it depends on what disease he has got. If he has got thrombus in the inferior vena cava, which happens in RCC, which is going to the heart. Yeah,
I'll just take that question, sir. So actually, what Dr. Dhar is trying to say that a lot of times it is in medical science we don't say 1 + 1 is 2, and all these surgical protocols a lot depends on the personal experience and personal learnings, especially regarding anticoagulation. I'll tell you there are huge sum of guidelines for different societies, be it a surgical society, be it an interventional radiological society. Overall, you have to weigh the risk versus benefit ratio. So there are certain surgeons who would feel that with new advancements that even stopping ecosprin for 1 or 2 days should be good enough. But there are surgeons, especially in Western world, sometimes some countries would want to wait. So it is also depends on the national guidelines. not just the international guidelines. So
So,
Doctor, so that's my point. Why don't India have any national guidelines?
we have, sir. We have.
Or a HP or a homophobe.
No, we have, sir. There are standard guidelines. Again, regarding a particular patient, a particular instance, it lot depends on what the complexity of the surgeon is.
this exchange proves how much angst the cancer patient and his caregiver goes through. We are fully out of time, but it was great having. There's one last question or comment. Quick, please.
Can we get the mic? We'll try and keep this short and crisp. Just a request. That's
Yeah.
it.
Please bring it closer to you. Dr. Dhar.
Cervix vaccine is very safe. There are definite national and international guidelines, but the only thing is it should be given properly. It should be given to the girls who are between 9 to 12 years of age, school going girls, and the person who receives cervical cancer vaccine, they should be sexually unchallenged. We married people can take it, but the efficacy of the same vaccine will be lesser in married people as compared to those who are sexually unchallenged. Suppose we get 90% efficacy in a 9 years old girl, the same efficacy will come down to 30% or 25%. So that is a very important thing. There were earlier few myths about that this is not safe, but it has to be given properly. It has to be given in a hospital setup by a trained doctor. ऐसा नहीं होना चाहिए डॉक्टर मैं सब्जी लेके आती हूँ आप मेरी डॉक्टर को वैक्सीन लगा दीजिए. That is not acceptable. Thank you.
So wonderful answer and wonderful close. Great panel. Thank you, everybody, and great audience. I do have one wish which did not get fulfilled. I did not get any comment from a cancer survivor, but maybe during the day those people also speak. And it was a pleasure being with you all. Thank you.